Welcome to Pharmacology.
Hello friends, today's topic is about sulfonamides. Basically, the sulfonamides are classified depending upon their T halves and their time of action. They are classified into short acting, intermediate acting and long acting. Short acting is they have around 6 to 8 hours of T half, and here intermediate acting they have 8 to 12 hours of T half, and long acting it will be around some 7 days of T half. So short acting, intermediate acting and long acting. The short acting ones are less plasma protein bound and the long acting ones are highly plasma protein bound. They are around 95% plasma bound and these are only 10% plasma protein bound. So and the last class is some special purpose sulfonamides. The first short acting sulfonamides we have sulfadiazine. Sulfadiazine is helpful in the treatment of meningitis. That is because it will be able to cross the blood brain barrier and it enters into the neurons, so in the brain, and so it will be helpful to treat the meningitis. The intermediate acting one is sulfamethoxazole. Sulfamethoxazole is used in combination with trimethoprim. The combination is a fixed dose combination which will be called as cotrimoxazole. Combination of trimethoprim and sulfamethoxazole. It is cotrimoxazole. Combination of trimethoprim and sulfamethoxazole. Cotrimoxazole. It's used as an antibacterial for the treatment of some toxoplasmosis and nocardia infections. It is helpful. And so sulfamethoxazole and sulfadiazine, both of them are giving out crystalluria as a side effect. So crystalluria is nothing but clouding up of the urine. They are giving out metabolites that are not soluble in the urine and then which are precipitating out, forming crystalluria. To prevent this, whenever sulfadiazine or sulfamethoxazole is given, patient should take more water intake so that the urine will be much diluted and then crystals are not formed, and otherwise the urine should be alkalinized by giving intravenous or oral alkalinizing agents. So alkalinizing agent in combination with these drugs are reducing the crystalluria adverse effect. Next thing is long acting agents, long acting sulfonamides, sulfadoxine and sulfamethoxazine. Both of them are having anti-malarial use. Both of them, either sulfadoxine in combination with the pyrimethamine or sulfamethoxazine in combination with pyrimethamine, will be used as anti-malarial. These both are the combination uses. That is sulfamethoxazole plus trimethoprim as cotrimoxazole and sulfadoxine or sulfamethoxazine in combination with pyrimethamine as anti-malarial. Both these uses are still being clinically used, whereas single uses in treatments are not still in use. Next thing is special purpose sulfonamides. In the special purpose sulfonamides, you have sulfacetamide sodium, which is used in the ocular infections as eye drops. Next thing is sulfasalazine. Sulfasalazine is used to treat ulcerative colitis and rheumatoid arthritis. In the ulcerative colitis, usually there will be diarrhea and with fluidy watery kind of diarrhea. The sulfasalazine is possessing anti-secretory kind of activity which will suppress that kind of diarrheas. And in the rheumatoid arthritis also, it is used in treatment of ulcerative colitis and rheumatoid arthritis. Next thing is mafenide. Mafenide and sulfadiazine, both of them are used topically in the treatment of burns. Both of them are used as preventive measures to avoid infections on the burns. And apart from that, mafenide will be having activity as anti-pseudomonas as well as anti-clostridia. Other than that, silver sulfadiazine, you can see that silver is there. any metal will act like an antibacterial. So silver sulfur diazine, on the other hand, it is also an antibacterial. So silver sulfur diazine has antibacterial activity, as well as it is compounded as a cream and used in the treatment of burns and ulcers on the skin. Sulfonamides are the first antimicrobial agents that were ever used against the pyogenic infections. So what are pyogenic infections? Pyogenic infections are nothing but the infections in which the pus will be formed. So sulfonamides were first used to treat the pyogenic infections. What happened actually is a sulfonamide containing dye, which was called as prontosil red, was first used experimentally against streptococcal infections on animals, and which were treated successfully. Then came the class of antimicrobial agents, sulfonamides. When they were introduced, they were broad spectrum antimicrobial agents. That is, they were active both on gram-positive as well as gram-negative organisms. When they were introduced, actually, they were active against Staphylococcus aureus, Escherichia coli, gonococci, meningococci, etc. Like that, they were active on many of the gram-positive as well as gram-negative organisms. But many of these organisms now, they have developed resistance against the antibiotic. And then when they were actually introduced, they were also active on many of the chlamydia and actinomyces. Actinomyces like toxoplasmosis and nocardia are still sensitive to this sulfonamides. Even now the sulfonamides are used to treat the nocardia and toxoplasmosis that are coming because of this actinomyces. That is about the spectrum. So they were introduced as broad spectrum antibiotics. Later on, the organisms, they have developed resistance to the antimicrobial agents. Bacteriostatic agents. They are basically bacteriostatic in nature, not bactericidal. Bacteristatic means an agent or an antimicrobial which can suppress the growth of the bacteria, but not killing. Killing can be termed as bactericidal. So these are only bacteristatic agents. Whereas when the sulfonamide is taken and then it is metabolized and excreted in the urine, in the urinary bladder, they act as bactericidals. So they are bactericidals in the urine. Normally they are bacteristatics, but when excreted in the urinary tract, they act as bactericidals. Because of their high concentrations in the urine, they act as bactericidals. Next thing is, let us go through the mechanism of action. So single line mechanism is, they inhibit the bacterial folate synthesis. So bacterial folic acid synthesis will be inhibited. Folic acid, usually the structure of folic acid is composed up of three different things. One is para-aminobenzoic acid, called as PABA in short, and then the other one is pteridine, and the next one is glutamate. So folic acid structure contains para-aminobenzoic acid, pteridine and glutamate. Now let us see the synthesis of the folic acid in the bacteria. Dihydropteridine will be reacting with the para-aminobenzoic acid to give dihydropteroic acid. Dihydropteroic acid in turn gives rise to dihydrofolic acid, which further gives rise to tetrahydrofolic acid. So the conversion is dihydropteroic acid to dihydrofolic acid to tetrahydrofolic acid. So dihydropteroic acid will be formed by dihydropteridine reacting with PABA. So dihydropteridine plus PABA in the presence of dihydropteroate synthase. Teroate synthase indicates that dihydroteroic acid will be formed. Dihydroteroid synthase is an enzyme useful during the synthesis of dihydroteroic acid. So now dihydroteroic acid in turn will react with the glutamate. In the presence of the dihydrofolate synthase, it will give rise to dihydrofolic acid. Dihydrofolic acid will be reduced to tetrahydrofolic acid in the presence of dihydrofolate reductase. So dihydroteroic acid to dihydrofolic acid to tetrahydrofolic acid, the conversion will be going on, and then this tetrahydrofolic acid is useful for the production of DNA, RNA and protein. So tetrahydrofolic acid in turn will be metabolized to different nucleic bases and amino acids. Nucleic bases are helpful for the formation of DNA and RNA, and amino acids are helpful for the formation of proteins. So tetrahydrofolic acid or a folate will be, or the folic acid will be helpful for the production of nucleic bases and amino acids. Nucleic bases which are helpful for the production of DNA, RNA, and then amino acids that are helpful for the biosynthesis of the proteins. So in turn, what is happening is our sulfonamides go and inhibit the dihydroteroid synthase, because sulfonamides are structurally similar to the PABA. They are structurally similar to para-aminobenzoic acid. So instead of para-aminobenzoic acid going and binding to dihydroteroid synthase enzyme and getting converted to dihydroteroic acid, our sulfonamides go and interfere with that. They themselves go and bind with the dihydroteroid synthase and inhibit the formation of dihydroteroic acid formation, thus inhibiting the whole process of formation of tetrahydrofolic acid that will be helpful for the DNA synthesis, RNA synthesis and protein synthesis. So what is that? Sulfonamides are structurally similar to that of the para-aminobenzoic acid. They interfere and bind with the dihydroteroid synthase and they inhibit the formation of tetrahydrofolic acid, which in turn will be inhibiting the production of the DNA synthesis, RNA synthesis and the protein synthesis. That is the mechanism of action. Now we are using these drugs to treat the infections that are actually caused by bacteria when bacteria is invading the human cells. So we are using the antibiotics or this antimicrobial agent sulfonamides on ourselves. So we may get doubt that the folic acid synthesis or the biosynthesis inside the human body may also be altered. Here the human cells are using the dietary folic acid. So human cells are using dietary folic acid. They are much dependent on the dietary folic acid. So though the folic acid synthesis inside the human body will be also affected by this mechanism, there is no depletion of folic acid in the human body because the human cells are much dependent on the dietary folic acid. And also the PABA supplementation, pus and tissue extracts are going to inhibit the activity of the sulfonamides, because PABA, para-aminobenzoic acid, here we have seen that in the mechanism of action of the sulfonamides, that the sulfonamides are structurally similar to PABA and they compete during the process of inhibition of the dihydroteroic acid formation. What they are doing is they are competing with the PABA. They compete with PABA and they bind with the dihydroteroid synthase. During this competition, if there is excess of PABA, then that may win the competition and then go and bind to the dihydroteroid synthase and carry out all this process, and that will be inhibiting the functioning of the sulfonamides. So if the PABA supplementation is given, that will be inhibiting the functioning of the sulfonamides and suppresses the activity of the sulfonamides. And next thing is pus and tissue extracts. The pus will be having PABA in it. So the PABA that is present in the pus may further inactivate the mechanism of action of the sulfonamides, and they may suppress the activity of the sulfonamide. Next thing is tissue extracts. Pus and tissue extracts, both of them, they contain purines and thymidines. Purines and thymidines are nothing but the building structures of the DNAs and RNAs. So we are telling our tetrahydrofolic acid or our folic acids are responsible for the formation of DNA and RNA. And if there is excess of pus and tissue extract which is having more purines and more thymidines present in it, those are actually helpful for the DNA and RNA formation. So suppressing the activity of the sulfonamides. So this is how the human cells are not affected by the sulfonamide action, as they are dependent upon the dietary folic acid, and then PABA supplementation will be suppressing the activity of sulfonamides. Pus and tissue extract also will be inhibiting the activity of the sulfonamides. Next, coming to the resistance development in the organisms. Just now we have seen that many of the gonococci, meningococci, and Escherichia coli, Staphylococcus aureus, all these organisms, they have developed resistance against the sulfonamides by this various different mechanisms. One thing is excess of PABA secretion. If they secrete excess of PABA, that PABA will be inhibiting the sulfonamide activity. It competes for the dihydroteroid synthase, and then it will be carrying out all the whole process, thus inhibiting the activity of the sulfonamides. Next thing is reduced affinity of folate synthase. So this folate synthase is nothing but this dihydroteroid synthase. So the dihydroteroid synthase affinity towards the sulfonamide, if it is reduced, it goes and binds to PABA easily, but it cannot bind to the sulfonamide. In such a way, the sulfonamide mechanism of action will be stopped and rendering resistance. The organism then renders resistance towards the sulfonamide activity. Next thing is alternative path for the folate metabolism. Not this path, some other path will be followed by the bacteria that will be helpful for the production of the folic acid, that will be further helpful for DNA, RNA and protein synthesis. Thus bypassing this, some other process will be helpful for the formation of the DNAs, RNAs, suppressing the activity of the sulfonamides. So that is about the mechanism of action and resistance mechanisms developed by the organisms against the mechanism of sulfonamides. Coming to the pharmacokinetics, these sulfonamides are orally absorbed very well, and then they are undergoing extensive plasma protein binding, usually around 10 to 95% of plasma protein binding they are undergoing. Some of the sulfonamides which are long acting will be around 90 to 95% plasma bound. Because of that extensive plasma binding, they are long acting. And then some of the sulfonamides which are intermediate acting and which are short acting kind of sulfonamides, they are only 10 to 15% plasma protein bound. So because of very less plasma protein binding, their lifespan or the T-half is also less usually. And after plasma protein binding, they are extensively distributed throughout the body fluids, and then they are actually metabolized in the liver to inactive metabolites. But in turn, what is happening is actually they undergo an acetylation, and during the process of acetylation, less active metabolite will be formed, and these less active metabolites are having less solubility in the urine. So sulfonamides, they themselves are less soluble in the urine, and even their metabolites are also less soluble in the urine. So now these less soluble metabolites are likely to cause toxicity in the urine. Because of their less solubility, they crystallize in the urine. They form a cloudy urine. That will be called as crystalluria. It will be called as crystalluria. So less soluble metabolites that are coming out after an acetylation process, and the sulfonamides itself are less soluble in the urine, and they are crystallizing in the urine, forming a cloudy urine. That will be called as crystalluria, which causes irritation to the bladder, and then it may also develop a renal toxicity. So usually people who are having acute renal problems or some renal problems should take very less doses of sulfonamides. So dose reduction is needed in such kind of patients. Next adverse effects are gastrointestinal effects. After taking sulfonamides, the person may feel nauseating, vomiting, and some epigastric pain in the stomach. They may feel some kind of pain. Next thing is hepatitis. Hepatitis, hemolysis, and hypersensitivity reactions. Here you get 3 H's at a stretch. So hepatitis, hemolysis, and hypersensitivity reactions. So it may cause hepatitis, some inflammation in the liver. And the next thing is hemolysis, and especially in case of people who are having genetical deficiency of glucose 6-phosphate dehydrogenase. Glucose 6-phosphate dehydrogenase. This enzyme, which is present in the blood, will be responsible for the lifespan of the RBC. People who are having genetical deficiency of this enzyme, if they are taking any drugs that are active on the RBC becomes fragile and it will be lysed off, leading to hemolysis. In this case, sulfonamides act on the RBC and they lyse off the RBC when used in the people who are having glucose 6-phosphate dehydrogenase deficiency. So that is about hemolysis. Next thing is hypersensitivity reactions, or allergic kind of reactions are coming over, especially rashes throughout the body. Urticaria also prevails. And next thing is Stevens-Johnson syndrome, which is a fatal cutaneous reaction, and then also some mucocutaneous reactions. Exfoliative dermatitis kind of adverse effect is also noticed. And then next thing is kernicterus in the newborn. Kernicterus in the newborn. It is happening because in the newborn, whenever sulfonamide is given, that goes and enters into the blood circulation. There it will displace all the protein bound bilirubin will be displaced off, and the bilirubin will be freely circulating inside the blood, and happily it crosses the blood-brain barrier, it enters into the brain, and then it causes some damage to the neurons in the brain. That will be leading to the mental retardation in the babies, and leading to vision problems and hearing loss. All these effects are coming out. That is nothing but kernicterus. Kernicterus occurs in the newborn if they are taking sulfonamides, and topical use of these sulfonamides is almost not done because of the skin reactions that are likely to occur after usage of sulfonamides. And sulfonamides are also causing photosensitivity. So after taking sulfonamide, if a person gets exposed to sun, it causes allergic reactions over the skin. That is called as photosensitivity. So crystalluria, GI effects, and hepatitis, hemolysis, hypersensitivity reactions, and kernicterus, exfoliative dermatitis, photosensitivity reactions, rashes, urticaria, Stevens-Johnson syndrome are all the adverse effects related to the sulfonamides. Thank you. This is all about the sulfonamides, made in short for you people. If you like the video, I hope you will subscribe it and encourage us.